And what the study looked at about 110 odd patients was that there were about 30% such mutations present in the co-binding factor with inversion 16, and there was a differential in terms of the kind of mutations that happened in the c-KIT also. So there was a c-KIT mutation of c-KIT at 17 exon, and there was a c-KIT mutation at exon 8. And they all had a differential output. But overall, if you had a c-KIT mutation with an inversion 16, they tend to do worse than if they did not have a c-KIT mutation. And that was true for even the 821 translocation. But what needed to be understood is that if you look at the curve over here in the bottom part, those with the mutation c-KIT 8 with exon mutation 8 were the worst in terms of, did not have too much of an impact. They had a low relapse, they had a high relapse-free survival, whereas those with the mutation in exon 17 had a much worse outcome than those with other types of c-KIT mutation. So the role of transplant, then again, what about NPM1? We know that doing a transplant for NPM1 is a favorable molecular profile in these patients, and especially when they are associated with the FLT3 negativity. And we know that doing a transplant in these patients have no great benefit. And this was published again in the New England Journal in 2008. But what about presence of an MRD positivity by PCR for NPM1 at the end of induction therapy? When you have an NPM1 mutated patient, irrespective of whether they are FLT3 positive or FLT3 negative, they have a worse outcome if you have an NPM1 minimal residual positivity at the end of induction, and they may be served better by undergoing an allotransplant. So we have to go through all these things, and I will just rush through in the interest of time that the European Leukemia Network has laid down some guidelines, and wherein they have looked at cytogenetic markers, the molecular markers, and the clinical features, laid down favorable and adverse prognostic profile, put a score for them, and this is available in the literature. It's difficult for me to go through the entire thing, and you have a scoring pattern. And if you were to look at doing a reduced intensity transplant for myeloid leukemia, especially in the older age group, there is a marginal benefit for the myeloablative conditioning as against a reduced intensity transplant, because the relapse rates are, even though the transplant-related mortality in reduced intensity transplant is less, the relapse rates are a lot more for a quick transplant. So in conclusion, allogenic transplant is a preferred treatment for CR1 for intermediate and poor risk group. In favorable risk group, the risk versus benefit ratio does not favor a transplant. However, there may be some exceptions that you want to look into. And reduced intensity condition has probably a similar survival as compared to a myeloablative conditioning regimen. So transplant, then we'll talk about transplant in the relapsed refractory AML. I don't think there is any confusion over here in terms of doing a transplant. Wherever there is a donor available, it needs to be, the patient needs to be transplanted ideally. But we also need to take into consideration who are the patients who are actually going to really benefit following a transplant. There are various scoring systems, etc., that have come into play. We know that this paper from 1996 from ST and group clearly said that if you have a time to progression which is much more prolonged as against a short time to progression or short time to relapse, the patients with a short time to relapse obviously will have a much worse outcome. And again, going back to Alan Burnett's paper, we do understand that patients in CR2 do benefit with a transplant, and there is no questioning that. There is significantly better outcome of survival as against those who did not undergo a transplant in that study. So Kurosawa looked at the various parameters that would predict the outcomes in a relapse setting, and if you look at age, which is greater than 49, if you look at the time to relapse, which is greater than 1 year, how many courses of induction therapy required to go in for a remission status, again, the cytogenetic risk group had an important role to play, and also whether the patient, of course, underwent a salvage hematopoietic stem cell transplant or not. And again, the other aspect was if the patient had undergone a hematopoietic stem cell transplant, whether this was a second transplant, versus also a patient who went into CR2, went into remission following treatment, and then again had a relapse. In fact, typically a CR3, and those patients also had worse outcomes. Similarly, allotransplant, depending upon the CR1 and CR2, this is just to reiterate the point that I said a little while ago, patients in CR1 tend to do better. If you have a primary induction failure, they do the worst, and of course, patients with a relapsed refractory disease have the worst outcome. So there are certain scoring patterns, there are several scoring patterns actually that looked in the relapse setting, which looks at who are the patients who are going to do well. One of the simpler ones is a Golem scoring system, where they look at three parameters: the FLT3, presence, absence, the karyotypic abnormality, and the CR1, whether it's greater than 12 months or less than 12 months, and give a score of 0 to 3, and depending on lower the score, the better the outcome in these patients. So there are no prospective comparison between transplant versus no transplant, but the prognostic score, depending upon age, relapse, baseline, etc., have a kind of gives us a semblance of understanding who are the patients who are going to do well. Definitely, if you want to look at cure, allotransplant is a way to go about it in these patients, and not much to choose between different salvage chemotherapies. And we may have a better outcome in patients in CR2 doing a transplant as against not doing a transplant. The last part of my talk is the new thing about MRD, whether we can use MRD to choose or make a decision on doing a transplant for these patients. So we know that as is true for many of the diseases, as is true for myeloma, acute lymphatic leukemia, and several other hematological malignancies which are again evolving, myeloleukemia is also no exception. But the problem with doing MRD studies as against lymphocytic leukemia is that you have to look at several markers, and because of the sheer heterogeneity of the disease, we have to have a baseline, if you're doing by flow cytometry, you'd have several markers that have to be there at baseline, which have to be looked, and we also have to look at the leukemia specific antigen to see whether we are actually looking truly for an MRD disease. But it is sort of evolving, and it is much easier to do an MRD study for example, by a PCR for an NPM1 mutation or a FLT3 mutation as against doing a flow cytometric evaluation for these patients, because it needs a much larger panel. But we do understand that concept does exist, and there is science behind it, and while the poor cytogenetic profile still holds fort, if you are having MRD positivity in terms of FLT3 mutated MRD at the end of induction therapy, they tend to do worse. And similarly, if you're having MRD positive status in the intermediate risk group as against having an MRD positive status in the favorable risk group, that there is a difference in terms of the outcomes, with MRD being positive in the intermediate risk group having a worse outcome as those who are having MRD positivity in the favorable risk group. So this was a paper published in 2016 in the New England Journal by Ivy et al., which looked at clearly a more refined technique, where they looked at the MRD positivity at the end of induction therapy, and clearly there was a huge difference, almost a 3-time improvement in the outcomes for those who achieved an MRD negative status following induction therapy. And of course, the relapse-free survival in these patients also were far better. Similarly, when you looked at the FLT3 mutations, whether they were present or absent, and there's a repeat of the slide, in presence of NPM1 positivity, MRD positivity, those patients who had NPM1 positivity at the end of induction, they tend to do worse than those who are negative, and again would be a candidate for a transplant. And again, not so much for the DNMT3A, they are driver mutations for an AML, and even though the presence of the DNMT3A3 positivity at the end of it is not as robust as some of the other markers for AML. So can transplant negate the poor prognostic value of MRD positivity? Well, that is again an evolving science. We do understand that MRD positivity just tells us that we have a poor biology of the disease. Whether transplant will overcome that remains to be seen. But there are some indications that transplant perhaps is better off for an MRD positive patient as against MRD. There are studies to say that if you are MRD positive, their outcomes are worse or as bad as a patient who's having evident blast at the end of induction who will need to undergo a transplant. So when you look at MRD positivity, if you're doing an autologous transplant, as again, this is one of the studies which is again unpublished, which looked at auto versus allo in these patients, and there is a decrease in the MRD negative positivity status following an allo transplant in these patients. And similarly, there is how the degree of MRD positivity, if you have a very high MRD positivity as against an intermediate MRD positivity, as against a negative MRD status, then those patients tend to do differentially, with high MRD positivity being the worst. So in conclusion, MRD may refine the pre-transplant prognostic allocation to more realistic category risks. The graft versus leukemia effect may control MRD, but if we are looking at high MRD values, perhaps it is not as effective in controlling the disease. MRD monitoring again may help in predicting an impending relapse, as we know when you do the BCR-ABL transcripts or CML log increase, etc. But that is again an evolving field, but certainly something that can be looked into. And there may be a role to decrease MRD further by additional therapy. So that is why you're looking at consolidative measures. So looking at agents such as midastaurin for FLT3 positivity, looking at azacitidine hypermethylating agents in patients who are MRD positive to try and get them into an MRD negative status. These are all strategies that may be looked into, and thereby suggesting that immediately jumping into a transplant for an MRD positive patient may not be the way to go. There needs to be more efforts to try and get it to a lower ebb, so that once we do a transplant, the graft versus leukemia effect will be more effective in this situation. So I'll conclude with this last slide, saying that the indications for transplant for AML has evolved, and as you see, as a broadening of the arrow, we know that favorable risk profile most of the time does not require a transplant. Intermediate risk profile does require, but we have certain molecular profiles within them which are doing well, and we don't need to do a transplant. Certainly, adverse profile does require a transplant. Secondary AMLs with myelodysplastic features certainly also require a transplant, but we do understand more recently last week's Blood article which talks about MIRAGE as if they are present, the MIRAGE features which are present, they do very badly even with a transplant. And now we are dealing with MRD positivity and negativity to determine whether even a patient which is independent from the baseline cytogenetic and the molecular profile, for us to determine how we need to do a transplant for these patients. And this is, and I conclude here. Thank you. Consolidative measures. So looking at agents such as midastaurin for FLT3 positivity, looking at azacitidine hypermethylating agents in patients who are MRD positive to try and get them into an MRD negative status. These are all strategies that may be looked into, and thereby suggesting that immediately jumping into a transplant for an MRD positive patient may not be the way to go. There needs to be more efforts to try and get it to a lower ebb, so that once we do a transplant, the graft versus leukemia effect will be more effective in this situation. So I'll conclude with this last slide, saying that the indications for transplant for AML has evolved, and as you see, as a broadening of the arrow, we know that favorable risk profile most of the time does not require a transplant. Intermediate risk profile does require, but we have certain molecular profiles within them which are doing well, and we don't need to do a transplant. Certainly, adverse profile does require a transplant. Secondary AMLs with myelodysplastic features certainly also require a transplant, but we do understand more recently last week's Blood article which talks about MIRAGE as if they are present, the MIRAGE features which are present, they do very badly even with a transplant. And now we are dealing with MRD positivity and negativity to determine whether even a patient which is independent from the baseline cytogenetic and the molecular profile for us to determine how we need to do a transplant for these patients. And this will conclude here. Thank you. In version 16, they tend to do worse than if they did not have a CK mutation, and that was true for even the A21 translocation. But what Vikram and Biju may have something to say about the advantage of doing autologous transplant in AML. As far as I know, it is just another good consolidative measure for patients because you're giving high doses of chemotherapy and you're able to probably negate the because giving high dose cytarabine is not an easy thing many a time for many patients. So you may be able to abbreviate the number of cycles of consolidation, but it is again a more refined form of consolidation. Biju?
I think it's only the MRC who showed
the same scenarios. Would you give chemotherapy for the same blast crisis?
Currently no, but the question, that answer is quite divided actually. Many people do give some induction therapy because